843-9166 to reach tech support. I'd like to now introduce Bill Smith, who's the Executive Director of the National Coalition of STD Directors in Washington, D.C. And NCSD represents state, territorial, and large city health departments funded by the Centers for Disease Control and Prevention to carry out STD prevention activities. NCSD promotes sexual health through a specific focus on preventing STDs, and its area of work involves policy, advocacy, promoting health equity, and technical assistance and capacity building. With that, I'll turn it over to Bill.
Thank you so much, Ariana, and good morning, everyone. I'm looking at more folks joining online here, and it looks like we've got a very good crowd this morning. That was Ariana Childs-Graham, who is NCSD's lead on our billing and reimbursement project. So let me really begin by thanking Ariana, as well as two additional colleagues from NCSD, Burke Hayes and Stephanie Arnold-Pang, for helping organize all of this today. I also want to thank APHL, who's become such a great partner with NCSD as we face a number of challenges for both of our members on the challenges and opportunities of the transforming healthcare environment. And I'm very thankful that Karen's on the phone today and that this webinar is being jointly sponsored by both our organizations. I want all of our members to know that APHL and NCSD are working closely together, collaborating and working to make sure that we're leveraging the resources that we've got for the benefit of both of our members. Let me also thank the CDC for supporting this effort. The CDC is making some additional investments in billing and reimbursement, as many of you may know, through such projects as the Infertility Prevention Project and some of the additional training centers that will be funded in the next round of funding that is sort of the next generation of the current IPP project. Their investments there and their investments in CDC, I think, are paying off big time to make sure that we're working hard to make sure that our members are well prepared for the transforming healthcare environment. Just very briefly, the purpose of the webinar this morning I think probably doesn't need much introduction. It's really about working with our members and partners to diversify the revenue stream. NCSD and other partners work intently here in Washington on Capitol Hill, and as many of you have heard us say before, we are hearing consistently and increasingly that there are pressures to further cut back the discretionary money that the federal government gives to a number of projects, including those at CDC, which ultimately make their way to NCSD's own members. And part of that discretionary cut is focused on duplication of services and the opportunities that the expansion of healthcare and insurance coverage provide for covering healthcare services. So this is an issue that is not just real, but increasingly creating pressures for all of us, and of course all of you know that. So that's the purpose of this webinar this morning, really to focus on the diversification of revenue. NCSD will be creating a number of additional resources for our members as well as broader public health partners that will be released at our annual meeting later this year that include a number of additional models that are currently operational in the field and that are showing some good success in diversifying revenue and ensuring that the continuation of safety net services, particularly safety net sexual health services, are provided. Finally, I just want to thank our presenters from Michigan this morning, not just for your willingness to present today, but also your ingenuity and leadership in exploring this new venture together and across your program. So Chris, Judd, and James Roderick, thank you so much for joining us today, and I will turn it back to Ariana.
Thanks, Bill. I now have the pleasure of introducing our first presenter, Christine Judd, who's the STD Administrative Manager with the Michigan Department of Community Health in the STD Control Program. Ms. Judd has served in the field of STD-HIV since 1988. She began as a CDC Public Health Advisor and has worked with the Michigan Department of Community Health since 1995 in various capacities. Currently, she serves as the STD Administrative Manager, providing operational oversight to several program components. And with that, I'll turn it over to you, Christine.
Thank you, Ariana, and thank everybody for being with us on a Friday afternoon. For STD program managers, the concept of billing our clients frankly makes all of us cringe just a little bit. But that said, we also recognize that we are past that point of it being optional. So for Michigan, we fought it tooth and nail. We went through all of our stages of grief and finally said, okay, let's start by asking the gnawing questions. Do Michigan local health departments understand what 2014 may mean for them and federal funding? Are they taking the necessary steps to be in the running for reimbursement and funding in 2014? Is the Michigan Department of Community Health doing our part to assure that STD services will be available and accessible in 2014? Oh, and I just realized I didn't do the slide thing, even though I asked to have the ability to do that. So, my apologies. One sec. Burke? It's not moving my slide. Okay, there we go. Technical difficulties. None of the answers to these questions is a yes or a no. All of them, frankly, for us are sort of or partially. There's many reasons these questions became important for us. Obviously, the Affordable Care Act is huge. The changes that are coming as we approach full implementation in 2014 are occurring at the same time that funding levels for all government are shrinking. Okay. Sorry. For quite some time, every national conference or meeting has included at least one session that addressed the importance of billing. It became apparent that recovering costs through billing coding would be critical to assure our survival in the new public health landscape. Now for Michigan, add a new laboratory billing structure that Jim will be talking about shortly that affects our gonorrhea and chlamydia testing and publicly supported sites. We decided it was time to be an active participant in Michigan's STD future by becoming a better resource for our local health STD partners. Internally, we had discussions about what was happening in local health. We've been doing comprehensive assessments of program and clinical practice in our categorically funded jurisdictions for some time. We had an idea of what they were doing, but soon realized that although we knew that some jurisdictions were billing, we didn't know how they were doing it. We had no idea to what extent, particularly as it related to our clinical services. So then we thought, how do we help? Well, first we decided to get a better understanding of what was really in place. We developed a survey to ask the following questions. Is your jurisdiction billing? What services do you bill for? Who manages that billing? Which third parties do you bill? What is your payer mix? What are your challenges to billing private insurance and or Medicaid? What are your other forms of revenue? If you're not billing now, do you plan to? What's getting in the way? And what's your current electronic medical record status? I'd like to highlight just a few of the findings from our survey. The survey was sent to all of our local health jurisdictions in the winter of 2011. In Michigan, we have 83 counties and 45 health jurisdictions. Our largest jurisdiction actually includes 10 counties up in the northwest part of the state. Of our 45 jurisdictions, 23 responded, and of those 23, 65% or 15 are now billing, and the most commonly billed service is STD with 15 of the 23. All but one manage their billing internally. The respondents were a mix of our, I'm not there yet. Whoever just advanced, I'm not there yet. Thanks. We had a mix of small, medium, and large jurisdictions. And looking back, I sort of have a couple of limitations or disclaimers for our data. We only did hear, obviously, from half of our jurisdictions, with some of our major departments missing. We did this survey at a time when we had kind of surveyed them to death in our response because it was the holidays and because they were tired of us, I think. It was lower than we had hoped, so we have some limitations there. We did not distinguish in our survey STD programs that were already linked with family planning, and at least for us in Michigan, and I suspect nationally it's the same, those are our clinics who have a lot more experience in billing. Our division includes STD, HIV, and viral hepatitis, so our questions really focused on those services. Okay, next slide, thank you. Now, who are we billing, and what's our payer mix look like? So accepting Medicaid and Medicaid managed care, it is a great start. Jim's going to talk a lot more about our lab experiment, should I say? We did learn through that Medicaid managed care is a lot trickier than we thought. So that will be a big part of his. But we are excited that they've navigated that. Responses to the question of if the payer mix will change with the implementation of the Affordable Care Act, you'll see that as the last bullet there. If they expect their payer mix to change, 60% of them said they didn't know, which told us that all of those questions, those 9 questions we asked at the beginning, really are true. They're kind of partial or sort of. We're really in an area of a lot of uncertainty here in Michigan. Okay, next slide. On your screen are the most often cited challenges to billing that we saw in the survey. It's not surprising for us in STD that concerns related to confidentiality and explanation of benefits were huge, as obviously we work in stigmatizing infections and we serve a large number of adolescents. It's important, this piece is obviously very important, and it frankly doesn't seem to have a perfect answer. Dr. Redrick is going to be discussing in a little while the systems that we put in place in our laboratory billing that address this issue of confidentiality, but again, we're anticipating that we're going to have some bumps in the road as we move forward. Not really tied to the survey is when we talk to our partners about this topic, about billing and coding and everything, in Michigan, STD folks, both the people who work as DIS as well as the nurses and the clerks in our clinics, most of us, I should say, we're kind of old. We've been in this about 100 years, and all of them pretty much say, this is not what I'm trained to do, this isn't what I'm signing on for, and I wasn't hired to do that. So we've had those challenges as we move forward as well. Next slide. Okay. When we asked about other income sources, about half of the respondents collect either an established fee or a cash donation from the clients. In Michigan, that's usually like $5 here, $10 there, when it's just something more like a flat fee or a donation. 30% have a sliding fee scale in place, and about half acknowledge state funding. 76% are subsidized by their local funds. The way that we have things set up here is STD is one of the essential functions to actually be a health jurisdiction in Michigan. So they're all required to provide some level of STD services. So whether or not that state funding is acknowledging categorical, or if it's that we give our local public health operations money and they choose to put X amount of dollars in for STD, that part's a little bit squishy, but that was the result of the survey. Again, kind of lessons learned as we look back. Go back, thank you, sorry. One important point to note, though, is that at least here in Michigan, even though an increasing number of our jurisdictions are collecting fees or donations, not one ever denies service due to inability to pay. In state and local funds, I think Michigan's on the news all the time as being one of the hardest hit states with this economy, and we've reduced our funding significantly to locals over the last 2 years. That, coupled with the federal block grant going away, has put us in a position where we are forced to be prioritizing much, much differently, and we're at that point where we have to be able to do less with less. Okay, next slide. Thank you. When asked where our jurisdictions need the help, they overwhelmingly, as you see on the slide at 90%, said that they need technical assistance to establish billing and collections. Also significant were coding, confidentiality, explanation of benefit, and assigning a value to their services. I am pleased to share at this point one of our positive outcomes of the survey is it allowed us to respond to CDC's offer to provide technical assistance related to billing and reimbursement. Because of this survey, we were able to identify 2 sites that were kind of ripe for the picking, and both of them will be participating with CDC as they move forward with the technical assistance, and I'll be playing along to learn kind of the ropes, how to navigate processes, and hopefully it will allow me to assist some sites later on. Next slide, please. Thank you. In terms of electronic medical record capacity, of those surveyed, 65% do have EMRs in place. Of the 8 that said no, most of them, 70%, reported they're planning to move in that direction soon in the future. Of those that were surveyed, 15 use Insight, the public health software. What I also know from information outside of the survey is of the 45 jurisdictions in Michigan, 26 at this point do use Insight. It's allowed us to do some pretty creative things in terms of reporting on STD clinic activity, and we're working with the Bureau of Epidemiology to use Insight to do a lot more different reporting. And I can't get into it too much because I am not the person who's doing it, but I also know that it's been a big positive for us. And EMR is obviously critical if we're going to do billing effectively, so we're pleased that the majority of our sites are doing that at this point. Next slide. Okay, so we come back to those 9 questions. Obviously for us, the answers to all of them remain sort of and partially. We are encouraging our locals and have been to recover costs wherever possible. Our hopes related to billing are that locals are on board, they're moving forward, and that we at the department are finally learning a little bit more to become a resource for them as they move into 2014. Next slide. That's all I have on the survey. I'm going to turn it back over to Ariana and entertain any questions in a little while.
Thank you. And I would like to now introduce our second presenter. Dr. James Rudrick is the Microbiology Section Manager for the Michigan Department of Community Health, Bureau of Laboratories. He has over 25 years of experience in both the public and private sector in clinical microbiology, and he has been involved in the Michigan Infertility Prevention Project and the Region 5 Infertility Prevention Project for over 10 years. With that, I'll turn it over to you.
Good morning and good afternoon, everybody. In the next 20 or 25 minutes, what I hope to do is have a brief discussion about billing for laboratory services. I'll be the first to admit that I am not a billing expert, but what I hope to do is to stimulate your thoughts and perhaps stimulate a little bit of discussion based on our billing experience. And the way I'd like to do this is to look at our billing process from a historical perspective so that you can see some of the pitfalls and successes of our program. If we go back roughly a decade, in 2001, the Michigan Department of Community Health validated our first nucleic acid amplified test for GC and chlamydia. And that was going to be a replacement for GenPro PACE, which was a DNA hybridization system. The testing was going to be rolled out statewide, and of course we did a great deal of publicizing that we were introducing a new test that was going to have superior sensitivity and specificity over our current test. Now at this time, all the testing in Michigan was done at no charge, and testing was performed using the Michigan Regional Laboratory System. The Michigan Regional Laboratory System consisted of 6 laboratories that performed about 180,000 tests annually. And by using several laboratories that were geographically distributed throughout the state, we had several things in mind. First of all of our testing was done manually, and no single laboratory could handle the volume. The second was we'd hope to have a short transit time between the submitters and the laboratory, so none of our specimens would expire in transit. And hopefully, having multiple laboratories testing, we'd have a relatively rapid turnaround time. So if we look at what happened as a result of the change, in calendar year 2000, before we moved to the nucleic acid amplified testing, we performed about 183,000 tests. And of those, about 10,000 were by culture for GC. In calendar year 2001, when we switched to the nucleic acid amplified test, we performed about 260,000 tests. And obviously, the sensitivity increase that we promised was there. But also, the other thing is the number of cultures that were performed for GC dropped a great deal. So what was the reaction to what happened in 2001? Well, the first thing was, whoops, the laboratory overspent our budget for reagents by $300,000. And by July of that year, we were out of money. Fortunately, our chief medical executive was able to come up with some additional funds out of a discretionary account that he had, and we were able to finish the year. But we were told in no uncertain terms that this would not happen again. So we started brainstorming and looking for ways to maintain services but still control costs. And about a year later, we introduced what we called non-billed. We didn't want to use the term free testing, but non-billed testing requisitions. Okay, and these requisitions had a unique color-coded control number in the upper right-hand corner. And so that requisition could be used only once, and we could see where they were used and how many were used. At the same time, we also split our testing so that we performed combo testing, CT and GC, or CT-only testing based on disease prevalence in a given area of the state. So this change accomplished several things for us. The first is that the programs provided the non-bill requisitions based on the available funding. So we weren't going to go over budget. And the second thing is that our testing now became data-driven because we were looking at the prevalence of disease and putting resources where we'd get the most result for. Now, since we started what we called non-billed testing, obviously there had to be a second component, and that was billed testing. And in order to start billed testing, we started with let's go back. We did a cost analysis at our regional laboratories, and we found that we could establish a fee of $2.55 as the labor reimbursement for non-billed testing. But we also found that for billed testing, we would charge $36 for the combo testing and $32 for a CT-only testing. And all of that testing would be billed only to the submitter. There was no billing to insurance or Medicaid at this point. And for a couple of years, things ran fairly smoothly. The submitters recognized the dilemma that we had, and they thought that our fees were reasonable. In 2006, our billing expanded a little bit in that the family planning program received a Medicaid waiver for family planning services. And the name of the program was Plan First. Now, the primary goal was to decrease unintended pregnancy, but actually what the program did is financially it shifted 90% of the cost for the program from the state to the federal government. And the laboratories also benefited from this because we could now bill for testing services. And one of the key points that you need to know is that by law, no one can be charged a lower price for testing than Medicaid or Medicare receive. Now, at this particular time, the CPT, or cost per test codes, for nucleic acid amplified testing for a combo test was about $96. So we had some discussions about what we would charge. And because we still had providers who were paying for their testing, and these weren't going to be tests that went through insurance, we decided to stick with $32 and $36 for our fees. We also ran into our first major mistake here, is once we started accepting Plan First, people started asking us, well, will you accept all Medicaid? And we figured, well, Medicaid is Medicaid, and so we said sure. And we started receiving more and more claims for Medicaid, and we were able to bill Plan First and people with straight Medicaid, and we got paid most of the time. However, we quickly found out that we could not bill medical care organizations that were administering Medicaid because we didn't have an agreement with those insurance companies. And so for a period of time, the laboratory was either eating those costs or we were trying to bill the original submitter for rejected claims. And that was a point of contention. But we worked on that over the course of time. and things did get better. However, a few years later, things got particularly worse. The recession hit. The programs in the laboratories all saw budget cuts, and we saw staffing cuts as well. In a 12-month period, I lost about 30% of the staff in my laboratory. So we again had to brainstorm and start looking for cost-saving strategies. And some of the things we looked at is, could we perform testing in a more centralized fashion? And we again looked at billing as a source of revenue. Oops. So we again went and did a cost analysis of our regional laboratories. And we also looked at introducing automation. At this time, we were using the GenProbe Aptima test for GC and chlamydia. And their automated instrument called the Tigris could perform 350 combo tests in an 8-hour shift. And that would be the equivalent of about 87,500 tests annually. And in theory, one lab would be able to perform all the testing for Michigan. However, we decided to use a 2-laboratory system so we could guarantee continuity of operations. And in doing so, we found we could still decrease our costs by about $100,000. And that decrease in cost was due primarily to decrease in costs for proficiency testing, quality control, environmental testing, and labor costs. So we issued an RFP to our laboratories to select the second laboratory, and we asked them to give us a price per reportable result. And that price had to include all reagents, labor, and providing the collection kits to their assigned submitters. We also asked them to try and submit or to establish reimbursement agreement with the relevant medical care organizations that were administering Medicaid. But we also told them if they weren't able to establish those agreements, that the programs would try and reimburse their cost for claims that were denied. So we didn't want to put the burden of this testing or the cost for this testing back on the submitter. Concurrently, it was also decided that we were going to seek full Medicaid reimbursement for our testing. Try and get to the next slide here. Okay. So the full Medicaid reimbursement for a combo test was $77.08, and for a CT-only test was $38.54. And after a few delays, we decided that our starting date was going to be January 17th. And in addition to billing Medicaid, we were also going to move on and try and bill private insurance as well. Now at this particular time, MDCH was still doing their own billing, and we weren't doing a particularly good job. We were seeing a lot of claims denied, and we're having trouble dealing with Medicaid as a whole. So we started looking for a billing service who was going to perform that billing for us, and the contract with the billing service was actually signed in February of 2012. And the other issue is, at the time, Michigan still had no agreements in place with the private provider networks. Okay, so in August and September, we started preparing our submitters for billing. Our program coordinator had multiple conference calls and made multiple presentations that told our submitters that billing was coming and that the fees were going to increase. But in the background, we were looking for a way to minimize the impact of those increased fees for paid tests. So anybody who wasn't covered by Medicare or Medicaid or third-party insurance, we were still collecting a fee for that testing from the submitter. Now, our partners in family planning for years had been using sliding fee scales for their services, and we saw that as an opportunity, and we developed a sliding fee scale for laboratory services. And that's what's shown on this slide. So what you can see is on the left side are the fees that would be charged to the patient, and on the right side the fees that would be paid to the laboratory by the submitter. And the patient was also charged based on their income. Now, the nice thing about this sliding fee scale is that it's compliant with the Medicaid rules. So even though they may not be paying the full amount that we're getting from Medicaid, they're being billed that amount. And the other thing is, if you look at that carefully, you can also see that there was actually no cost increase to the sites for tests that they were paying for on their own. Okay, but there were several points of view to look at for our submitters. Certainly there were good points and bad points to the direction we were taking. On the good side is we were trying to prepare them for the Affordable Care Act, which, if it's implemented fully in 2014, we already know that there are going to be cuts in the federal funding that are provided to the programs for testing. So the programs have the opportunity to get ready for billing over the course of about a 2-year period, rather than having to jump into it all at once. We also told them that the programs would cover the cost for testing if the patient had Medicaid through a managed care institution, and we were not able to recoup the bill. And we gave them a way to start moving forward with this. That was using the sliding fee scale. Now, on the downside, there were several things that the program, or that the submitters were going to have to put in place. They were going to have to be able to collect fees in order to be eligible to use the sliding fee scale and pay the lower rates for tests that were billed to them. This was an entirely new system to them, and it may add some cost to their operation. They were going to have to set up a system to perform billing. They were going to have to keep records, and they had to be prepared to potentially pay higher rates for some tests if the billing claim was rejected. And also for STD clinics, collection of fees was an entirely foreign concept. And we were asking them to do all of this at a time when the economy was bad and they were faced with shortages of funds as well. At the same time, we had to prepare the laboratory for this. We had to redesign our laboratory requisition to capture, next slide, to capture the information not only for Medicaid, but also for third-party insurance. So we had to add information like the subscriber's name, their group number, and their contract number to our requisition. We had to reconfigure our laboratory information system to capture this new information. We had to create new queries to build billing files so that we could actually use that information for billing. And because we sort of got behind the curve a little bit, we had to design these new forms, get them printed, and get them out into the field in 6 weeks, and then try and remove older versions of all of our forms in a quick time frame. And then finally, we had to develop new invoices to capture billing using the sliding scale payments. As we were working on this, we also recognized that if we were going to bill private insurance, we had the issue of confidentiality to deal with. All of you are aware that a private party insurance will always send an EOB, or an estimate of benefits, to the home of the subscriber. And certainly for STD and family planning services, that's not always desirable. So we needed a mechanism to deal with this, and we came up with this relatively complicated algorithm which we provided to our submitters. And I'd like to go through this. If you start at the top left-hand side, if the patient was eligible for a prepaid test, certainly that was the way to go, and that's what we encouraged. If they weren't eligible, the first question to ask is, did the patient have insurance? And if the answer was no, the site should apply the sliding fee scale, and then the laboratory would bill the site. If the client did have insurance, then the question was, were they seeking confidential service? And if the answer was no, things were relatively straightforward. The laboratory would bill Medicaid directly. If the patient had Medicaid and a third-party insurance, Medicaid is the payer of last resort. So the laboratory would bill their third-party insurance. And of course, if third-party insurance was all that they had, we'd bill third-party insurance as well. However, if they requested confidential testing services, the plan changed a little bit. Certainly, the laboratory could bill Medicaid, and that wasn't an issue. But if they had Medicaid and a third-party insurance, in order to avoid an EOB going to their house, the laboratory decided that we would hold the bill and monitor the situation to see how big a percentage of testing this really was, and if the laboratory could just write off those costs. And then the third situation is if the person had third-party insurance only, the facility would then have to apply the sliding fee scale, and the laboratory would bill the facility for that testing. Now certainly, we have a lot of issues remaining. The next slide. We still had the issues of trying to bill managed care organizations. In May, Michigan signed a contract with Medicaid that would allow the state laboratory to bill medical care organizations for STD testing, and that those organizations would be required to pay us for those bills. So all along, we've been billing Plan First and straight Medicaid and getting bill and getting payment. Our first bills to the medical care organizations and actually to submitters since the beginning of the year are just going out. So we're still going to see how that process works. But as a new entity to billing, there were several policies that we had to develop and are still in the process of developing. How does the laboratory handle a specimen that's rejected? Whether that specimen comes in an expired transport, whether it's a urine sample that the tube is overfilled, or there's an incomplete requisition. Or maybe we get an indeterminate result, or if there's a laboratory testing failure. Certainly, we can't bill for the full amount, but because we've provided a collection kit, we've received the specimen, and we're issuing a report, we probably have the ability to bill for at least a small amount. And one of the unforeseen things when we moved to this was external competition. We're certainly seeing other people offering testing to our submitters for fees as little as $10. And that's actually below our cost for reagents. So now we're going to have to enter the field of marketing to make our submitters aware of the different quality of testing and hopefully prevail upon them that the quality of testing that we're performing is better than what's available from other sources. So we certainly have a great deal more work to do, and hopefully our process will be based on a common sense approach. But if not, certainly there is an alternative. And I think with that, I'll stop, and we can try and entertain questions.
Thank you. So we'll open the Q&A session now, and as Bill introduced Stephanie and Brooke earlier, they've been fielding questions that you've submitted during the presentations, and feel free to submit additional questions now, and they'll be sharing those, reading those aloud for our presenters to respond to.
So our first question, I think, is for Chris, and it says, how many STD clinics are run by local health jurisdictions in Michigan?
Well, as I was saying, every single jurisdiction to have health jurisdiction status in Michigan has to provide service. Of the 45, there's actually a dedicated STD clinic in all, but I believe 2 or 3. And how they handle services, they have agreements established with local providers, and they will refer and then pay that provider. These are in very, very rural and low morbidity areas in the state, though.
Great. So our next question is from Annabeth Elliott. It says, may we get a copy of the survey that Chris mentioned, and has Michigan State Department of Health pursued becoming a preferred provider of insurance companies?
Well, part of that's for me and part of that's for Jim. The answer to will we share our survey is absolutely. I will email it to Ariana this afternoon when I get back into my office in Detroit. Jim, you want to?
Okay, well, for the Medicaid portion, actually that's taken care of by the contract. By using a billing service, we're going to see what happens. We're just sending those bills out. We're going to see how many are going to be rejected. We don't actually think very many will be rejected, but we think the issues that are going to come up are going to be co-pays. The laboratory will have to decide if we're going to go back to the clients to try and get co-pays. And then we're also going to have to decide if we are going to accept payment for what the insurance companies offer. In many cases, even though we may bill $77, the insurance company may only pay $20, and we have to decide if we're going to accept that.
And if I could backtrack too, my contact information was there, and if somebody wants to email me directly, I'll send it to them directly. I didn't think of that.
Okay, so our next question says, since you utilize a sliding fee scale, how do you handle clients who don't slide to zero, but then say because they have to pay, they don't want the service? And then we have a slightly related question that says, even though clients were never turned away for inability to pay, do you think that a significant number of clients delayed or skipped screening or treatment due to charges?
Okay, I'm going to ask you to repeat the first one, but let me go ahead and answer the second one first. That was exactly our fear, and we don't really have control over what our locals do in terms of charging, but as time kind of passed and we kept hearing that, oh, so-and-so is charging $5, so-and-so is charging $10, one larger health department actually charges, up to $50, $70 depending on service. So yes, that was a huge fear. What I do know is only at least what I know exactly, is what I see, and we have these quarterly STD activity reports, which we've been doing for, gosh, on some level, at least 10, 15 years. Our numbers have gone down in a few of the larger jurisdictions. Unfortunately, Detroit's one of them. But the bug for us, or the rub, is that we don't know if it's just that they're charging or if it's other reductions that they've taken in staffing, clinic hours. We have one large jurisdiction that moved the clinic from an area that was very centrally located in a higher morbidity area to a little bit more rural place. So we suspect that it has had something to do with some of the reductions, but we don't know exactly how much. But yeah, I think that's absolutely a given. And Bert, can you repeat that first question? I'm sorry.
I think you actually kind of got it with the second one there.
Oh, beautiful. Okay.
Okay, so our next question is, what kind of technical assistance is CDC providing for the two clinics that the speaker mentioned? I think that was a question for you, Chris.
Yeah. A little while ago, maybe 2 months, CDC put out just a question to their states asking if anybody knew of individual health jurisdictions, local health jurisdictions, who wanted or could use, if they were in a place where they could actually use technical assistance related to billing and reimbursement. At that point, we had literally just finished our survey. So we went and we did sort of an analysis of if this, then that. And we had actually 3 jurisdictions who looked like they were eligible, and then 2 actually were totally eligible and accepted. The technical assistance is being funneled through Healthcare Education and Training, who's our IPP regional office, and it hasn't actually begun yet. They have a consultant that is going to be working through HCET and me, and I think it's getting ready to begin very, very soon.
Okay, wonderful. Just finding our second question. So next question is, beyond the STD and lab programs, were there other parts of the public health that were helpful in the process or shared learned experiences?
Certainly family planning. They were our biggest resource, would you say?
Yeah, and actually the laboratory, the only thing that the laboratory had previously billed for in Michigan was newborn screening, and that was through an entirely different mechanism.
Okay, how did you start the planning process, and did you contract with anyone?
We did not contract with anyone from the beginning. I would certainly encourage people who are going to go through this process to either contract with the billing service or at least start working with the billing service early on, so that you understand all the rules associated with billing, and to make sure you get your requisitions, your computer system set up correctly the first time. We've been scrambling multiple times because we're sort of learning as we go, and sometimes our things have been more reactionary than planned.
I would agree. It was a good investment.
Okay, so next question. How do you handle prior authorization requirements by Medicaid or private insurance?
That question has not come up yet. For Medicaid, when clients visit the site, the sites are supposed to confirm Medicaid eligibility, and that if it's a what's the name of the account? A flex account?
I think so.
Yeah, I think if it's a flex account, they're supposed to confirm that there's actually funding in that to pay for testing.
Okay. Okay, we're finding our next question. Just 1 second, please. Okay, so another participant asks, says, I'm working to get our regional lab contracted with third-party payers. The challenge that I'm having is that we perform immunizations and TB services and do not have a provider on site. We fall under our local health authority, and the insurance companies I have contracted are not sure how to contract with us. Does anyone have any solutions for that piece?
I don't know the answer to that. I'm sorry, I can't help you with that one.
Yeah, nor can I. I'm sorry.
Okay, just 1 second while we find our next question. Okay, what percentage of billed amount did the billing service charge?
We have the contract is negotiated as a flat fee for each bill, and our fee, the fee that we're paying, is between 35 and 42 cents. It's in that range.
Okay. Okay, did you need to establish contracts with private health insurance companies to become a provider before you were able to bill private insurance?
Our billing company is saying no, we did not have to do that.
Okay, next question. How do you plan on doing your marketing? What can you do to convince providers that a state or a county lab can compete with commercial labs?
Well, I think the main thing that we want to point out is not all amplified testing for GC and chlamydia is equal, and I think from what we've been able to gather, the folks that are offering the test for $10, this is a simple PCR-based test that doesn't offer target capture, and it is less sensitive and specific than what we're doing. So what we plan to do is try and write a letter or an article that basically tells them, if someone comes in and offers you another test, certainly we're not going to tell you you can't go with somebody else, but these are questions that you may want to ask them. Is, what's the sensitivity and specificity? What samples can be tested? Does the test have an FDA indication for symptomatic and asymptomatic patients? And then the other things are, how are you going to get collection kits to us? How are the results going to get back? So we'll encourage them to ask those questions, and hopefully if they are going to make changes, it will be an informed decision.
Okay, so our next question is, did MDCH require statutory authority to bill third-party and local health departments?
Apparently we had that all along. It just was never a policy to bill. We got that authority when they started doing testing for newborn screening.
And I could just follow up with that, Jim, and say that if there are states out there where you have a prohibition against billing, or feel that you need something codified in statute so that you can begin the billing process, please feel free to contact us at NCSD. We have a project underway that provides technical assistance to states that are looking to educate their lawmakers around the challenges associated with billing, and we're more than happy to help you with that. Okay, so we'll find our next question here. Okay, what credentials do the providers have in your clinics, i.e. are they RNs or APRNs or medical doctors? We have problems with getting providers contracted because we have mostly just RNs in our clinic.
We've got a huge mix in Michigan. Every jurisdiction and every STD clinic either has an on-site physician or has one that's, available to them, accessible to them. We don't all have nurse practitioners. Our clinics who are a combined family planning STD clinic, they generally have NPs because of family planning billing requirements, but we have a pretty big mix.
Yeah, the provider number that we collect on our requisition is usually for the medical director for the local health department.
Okay, great. Next question is, how do you bill a 17-year-old that comes in for confidential STD testing?
Well, generally, you ask if they have insurance and if they actually want confidential service. Basically, they're not going to be charged. And a 17-year-old, most of them don't have an income, so it becomes they're at basically zero on the poverty scale, and so the billing goes back to the submitter, or in a lot of cases in Michigan, those are clinics that are supported through either adolescent health, family planning, or the STD program.
Yeah, I remember at the beginning we were talking about the fact that Jim was, we have a set amount of forms that we send out that are prepaid, and we have very, very strict criteria as to who can and cannot be used, which clients they can use those for. But anybody who's 17 that walks in a door is generally going to be eligible for a non-billed test.
Okay, before we go to our next question, I just want to say that we're getting a lot of questions, and if we run out of time on this webinar, we'll make sure and get those questions over to our presenters to follow up with these folks individually.
Sure.
Our next question, let's just find that one real quick. Okay, if a person says they will not pay their portion of the sliding fee, do you still provide service? If you do, how do you handle that process?
They do. They do. That's what I was saying at the point where it's a negotiation between the local and the client, but they're not going to deny them service. If they absolutely, like say that I walked in the door, a 45-year-old woman with no risk, and I said that, there might be some negotiation that goes back and forth, and they may refer me, but by and large, are going to get tested one way or another.
Great. Okay, so what is the success rate for reimbursement from managed care organizations, and what are the barriers to such reimbursement?
Well, since our bills just went out or are going out in the next week, I can't tell you what the success rate is. I can tell you our success rate with Medicaid after we moved to a billing service has gone from about 40% up to in the 90s.
Great. Okay, so you stated that you did not need to get contracts with private insurance companies. Is that correct? And if so, are you getting paid often?
Again, those bills are just going out, so it's still sort of a stay tuned for us. Maybe there's something we still don't know, but the billing service is very confident that we're going to be reimbursed for those tests.
Okay, so what kind of training was implemented for providers in your clinic to orient them to the billing protocols and procedures?
Amy Peterson, our IPP coordinator, set up a series of required teleconference calls. She had some slides. She sent them out. Every single health jurisdiction, adolescent, venue, and juvenile detention that receives non-billed tests had to participate in one of these, and she explained the algorithm, what was going to be happening within the systems for billing, and also how that would and should affect them. So we required it, we documented it, and I'm sure I could get those slides and send them to anybody who would be interested.
Great. Okay, we'll go ahead and take one last question. And that is, will the individual counties have the authority to select the billing provider, or will RFP be necessary?
Well, actually, if they're doing billing on their own for services, that's strictly their choice. The billing service that we're using is strictly billing for laboratory services for Michigan Department of Community Health.
In terms of the clinic setting, all but one of the respondents is handling billing internally. So as far as the one who's not, I don't know what company they're using, or if it's health department wide or just for STD services.
Okay, great, Ariana. I think those are our questions. If you want to close out.
Great, thank you. And as Burke mentioned, any additional questions that we weren't able to address during the webinar today, we will be sharing with the presenters for follow-up after the conclusion of today's session. On behalf of APHL, NCSD, and our presenters from the Michigan Department of Community Health, thank you for joining us today for moving towards third-party billing and revenue generation in public health, an emerging model from Michigan. You will receive a follow-up message with details on accessing the slides from the presentations as well as the audio recording. This now concludes today's webinar. Thank you.
Thank you. Please stand by.